Diabetes is one of the most garbage terms I've ever heard of, okay? That's a really controversial statement because people act like diabetes is an on-off switch. You got to a point, now you're diabetic. No, it's not. You've been diabetic. Diabetes and pre-diabetes are exactly the same disease. People who have elevated A1C, even if they're controlled for diet and oral hygiene, meaning their diet is they're not eating sweet things, they're not eating sugary things, and they're brushing well, they have a significantly increased risk of caries. Why? Because actually the mechanism is that your gingival clavicular fluid has more sugar in it. So, if we talk about what biomarkers dentists should be aware of, we all should be aware of the HbA1c. I think one really interesting thing I'm finding with this, and particularly tracking this data, is I actually think there's going to be a ground-shaking change in medico-legal outcomes.
Dr. Tiff Qureshi taught us about the dial technique all the way back in episodes 16 and 17. Can you believe, Protrusive, that was 7 years ago? Now, Tiff is a phenomenal person, has a phenomenal reputation in dentistry. He is the dentist that talks about the lifelong patient, the benefit of being in one practice for many decades and seeing your failures and practicing preventive and functional dentistry. He's been talking about the envelope of function, getting dentists all around the world to understand this concept. And of course, how ABB, a bit of align, bleach and bond, goes such a long way. And he has proven through social media experiments that this technique can look just as good as ceramic veneers. But my friends, he's not here to talk about DAL or ABB or why you should take an intraoral camera of every single tooth during a checkup. Tiff Qureshi is here because he wants your blood. Okay, maybe not your blood, but the patients he sees in general dental practice, Tiff has been doing blood tests. He's become holistic, he's become biological. And biological Tiff thinks there are important biomarkers such as HbA1c and vitamin D that we should be testing as dentists in general dental practice. Now, blood testing in dentistry is not a new thing, but in primary care, it's still pretty niche. So Tiff is kind of like a pioneer. And what you'll gain from today's episode is the value of testing these biomarkers in dentistry. What is the risk-benefit analysis of this? And potentially, depending on what kind of practice you are, might inspire you to start introducing blood tests for your patients to ultimately benefit our patients and elevate the level of care we can give them. Now, this episode will be eligible for CPD, so watch out for the quiz at the end, available to our premium members on Protrusive Guidance app. And this episode as a PDP also qualifies for your Protrusive Dental Pearl. And today's Pearl is totally health related. Before you even think about introducing blood tests for your patients, are you looking after yourself? Are you checking your biomarkers at a suitable interval? I've been doing this for about 2-3 years now, inspired by Prav Solanki. And I absolutely love the data I get, and I was able to pick up initially that I was low on vitamin D. And now I have a few other things that I'm looking at. And it gets me interested in my health and longevity, and I eat better and I make better choices because I'm more vested in my biomarkers, and I want to make sure my biomarkers are as good as possible. It's like my competitive side inside me. That, I think, is the best way to do a deep dive in biomarkers, learning through yourself and your family. So my pearl today is get a blood test if you haven't already. There are so many different private services. I'm not going to name some because they're different in the UK to Australia to US, but things like HbA1c, vitamin D, iron levels, all the markers for your liver and kidney. It's something that a lot of people do every quarter. Now, you might start with that, and a bit like hygienist visits. If you're doing really well, then maybe you switch to 6 months and maybe then annual. For me, I'm at about every 6 months at the moment. And actually, my next one will be in 3 months because I did find a deficiency. When you do this for yourself, you end up like feeding into Gemini and ChatGPT, and you end up taking a real interest in your health. You get to understand a lot more. And that is the start of being able to even think about implementing this into practice and helping your own patients and discussing this with your own patients. So I think a real good actionable step from this episode is, if you're feeling inspired, and I know you will be because Tiff is an inspiring guy, the first step is to do your own blood test and then think about how you can implement this in practice. If you're not sure where to get started, you can message me on Protrusive Guidance and I'll DM you back with where I've got blood tests in the UK before and what kind of markers I've tested in the past and the future. So let's now join the main episode. I'll catch you in the outro. Dr. Tiff Qureshi, welcome again to the Protrusive podcast. Last time we did this was like COVID, right? I don't know if you remember. Do you remember?
I do remember, yeah. Lots of
it was
yeah.
That's right. And last time we talked about a dal. Why do some dentists find dal distasteful was the episode. And you know what? The podcast's come a long way since then. I remember the thumbnail that we had was the worst. In fact, I'll put it, for those who are watching, I'll put it on. It was like dal, as in the Indian curry dal, right? And then you, and then teeth. And it was like, it was just When I look back, I think, wow, we've come a long way. It's an absolute pleasure to host you again. It's about dentistry, right? But it's a little bit more left field, and I love that. It's about health and dentistry. It's about metabolic health, and I really am excited to learn from you because I attended your webinar some months ago about diet and nutrition and stuff. And I see what you put out there into the world about how to look after ourselves, and you've done a deep dive yourself. But for those who haven't heard of you before, there's very few people who haven't heard of you before. Tell us about you and your very fascinating career and the ortho stuff you do to the DAL. So you change the face of restorative dentistry and how we perceive DAL. And so you've done so much. How can you summarize that for us?
I mean, very briefly, I think a bit of luck, a bit of being in the right place, right time, working the right kind of practice where maybe my patients didn't have the money just to have a ton of work done. So I had to think my way around it a little bit, maybe being a bit brave to stick my neck out and start doing ortho and maybe start questioning what kind of ortho we should be doing, i.e. versus limited objective ortho in the right situation with the patient understanding it. And yeah, I mean, a lot of battles, but I think we kind of got to a point where most people certainly sort of respect what we're doing, what I'm doing, with the whole kind of concept of not align, bleach and bond, not just for aesthetics, but for function and longevity and keeping your teeth for life. I mean, that's what I realized. I didn't realize that at the beginning, but when I did align, bleach and bond all those years ago, it was all about making teeth look prettier. But seeing those patients again after sort of 5, 10, 15, 20 years, you realize that if you get, the anterior guidance correct, you get the function correct, the envelope function correct, you're retaining everything, you're stopping someone from eventually going to have a full mouth rehab. That's actually what you're doing. And that, to me, is what dentistry should be all about. So, yeah, I've kind of found my way here with a bit of luck and fortune and possibly also just the right frame of mind to get to where I am, which is probably why I've ended up with this area as well, I think.
Well, I just want to thank you from the profession in terms of what you've done for GDP orthodontics, for our understanding and the perception and development of how we think about the envelope of function. And this concept of the lifetime patient, right? And then not this, you're very much against the wham, bam, thank you, ma'am, let's do your veneers and off you go. It's about seeing your patients and being in one place for so many years. And that's really had a positive impact on my career over the years. So I want to thank, on behalf of the entire profession, the mindset shifts you've created. And there's another mindset shift that you're about to present to us in terms of, okay, what does the next 10 to 15, 20 years of dentistry hold for us when it comes to the integration of dentistry into the body and health as we know it?
Yeah, I mean, I think a lot of this stuff started with, I think during COVID, a bit after COVID, before after COVID. I mean, there are people passing away, and you get to the stage in your life when they call your 50s sniper's alley. Okay, that's the term. And you're not there yet, Jazz, but it's a very sad thing to say, but when you get to that age, before, a bit after, you're going to see lots of people pass away, and you're going to start to question why that's happened. And that always started many, many years ago, to be honest with my father. And I always thought that a lot of this stuff was genetic, and if you're Asian, this is going to happen to you. But what was really interesting once I started to reread into things, some basic things actually, was that there's a real kind of misconception in what is causing disease, and the evidence is there, but for some reason the medical profession doesn't seem to change. And I'm not saying the medical profession is wrong in what they're doing here, okay, but what I'm saying is that it always seemed to be about handing out some medication versus fixing the problem at the beginning. And of course, in dentistry, that really that triggers us, because we should be, we're all about prevention, and we're not conflicted by a pharmaceutical industry. So actually, we can really deal with root cause. So when I started to understand what root cause problems were, what were causing these problems, and ultimately, there's this thing called metabolic disease, that is fundamentally the core problem for most people. It is the primary driver for most diseases, ranging from, diabetes, kidney disease, various forms of dementia, heart disease, pulmonary disease. All these things are fundamentally driven by the same thing. And a lot of, some of those factors are also strongly implicated in dental disease. And so, it became really interesting that I needed to kind of understand this a bit more. I applied a lot of that thinking to myself. And those that know me, I physically changed, but not just physically changed. I've mentally changed as well, because I feel better. I'm more driven. I don't get sleepy. I don't get the afternoon crash, et cetera, et cetera, et cetera. And that all makes absolute logical, scientifically researched sense. I felt that if I can understand this, and I'm not a doctor, but if I can understand this, anybody can understand this. It's pretty basic stuff. And so I've really spent the last 5 years doing a bit of a kind of, a lot of this kind of research, practicing it on myself and N equaled 1 study. And then over the last 3 or 4 years, I've been talking to my patients about diet and nutrition much more as well. And in the last couple of years, I've started to actually do things like blood testing in practice, which we'll get onto at some point. But each time, it's validated everything that we've thought and uncovered things that I'm shocked that we didn't ever want to know this before, if that makes sense. So yeah, it's been a bit of a journey. I'm still on that journey, and I certainly don't know everything, and I'm certainly learning every day. But I think a lot of this stuff is really clicking together like a fascinating jigsaw puzzle that, this will all be by the end of my career, I'll kind of get it. For people who are younger, like yourself and many younger people, the great thing is a lot of this stuff's being uncovered for you now, which is wonderful.
Speaking of your journey, Tiff, I remember, you may not remember, you may remember this actually. I remember you did a post on Facebook. This is way before you started on so I'll call it a rabbit hole. Okay, I'm going to call this a rabbit hole of health and looking into your own health, right? And so that's a rabbit hole. And so I'm diverting again. I'm going around in different avenues, but I've always said in the podcast, there's 3 rabbit holes we should all go down. Okay. One is whichever profession you're in, you owe it to yourself to, you pick that profession, give it the best shot. So when it comes to dentistry, really immerse yourself into the art and science of dentistry. Give it your best shot, fall in love with it, develop it, find a passion within it, right? And so I always say in your career, do that. I also say do it in your personal finances. Realize the importance of saving, investing, living within your means, and compound interest, all that kind of stuff. And the other one is your health. So Prav has been a huge inspiration to me. I know he has been to you as well in terms of how he shaped my thinking about looking after my health. He got me into doing some blood tests myself, and I'm coming to the end of a 3-month keto experiment actually on myself, and I'm going to do some blood markers next week and compare. Okay, my blood pressure's gone down, but what else has changed in me? So I'm definitely in the same boat as you in my own journey. We're all on our little journeys, but I think it's great to inspire everyone what a wonderful area to go into. Your own health, and then eventually your family and those who love around you, and then your patients as well, which is exactly what you're doing. Now, going back to that Facebook post you did, you posted, you were sat on your couch and you're watching telly, and you posted this purple, I think it was purple yogurt pot, right? And it was like satisfaction in every pot. And you want to say, I want to thank Dairy Milk or whoever it was, basically, right? For doing this and like amazing and meeting their promise of extreme satisfaction. And I remember that post, right? And then we started to go health. And I love that. And I love that, you have this thinking, the way you think about something and how that changes. So it's probably been a while since you've enjoyed that satisfaction in a pot.
It is certainly. I haven't.
Do you remember this post?
I remember it. It was a something pot of joy.
Yes.
It was. And I think I said that actually meets the advertising standards.
That's right.
I mean, it certainly was a pot of enjoyment. If I actually, obviously now, I might title that slightly differently. But anyway, I shouldn't say anything negative about that brand, but just in case.
Other brands doing this, etc. But look, it's about having a shift, like you said, shift in your thinking, shift in your body, shift in your mindset. So based on what the deep dive and the rabbit hole that you've gone down to metabolic health and diet, there's so much we can talk about. I mean, you did that webinar with IAS, and that was supposed to be 1 hour, but I'm pretty sure it went on for 3 hours in the end. I had to leave after about like 45 minutes. But look, you're really passionate about it. You've done your research and you have these views which we'd love to share with everyone. And I think the way you should channel this conversation, starting with the root cause element that you mentioned, right? Now, you mentioned in medicine, find the root cause, but in dentistry, we have the same problem, right? Caries. It's primarily a sugar and diet issue, oral hygiene as well. But even if someone has poor oral hygiene, but their diet is good, they're unlikely to get caries, is my view on that. Obviously, saliva is really important and stuff. But so many times we give the fluoride and we do the restoration. And how much time in terms of coaching for the diet and actually being involved in that aspect do we have? So do you think we have a similar issue in dentistry when it comes to sugar?
Definitely. And I think part of the problem is the definition of what sugar is. There is a huge misconception of what sugar is. Patients just think sugar is what's in chocolate, what's in fizzy drinks, what's in whatever, table sugar. But what people need to understand is all starchy carbohydrates, all carbohydrates are actually sugar. Now, when you get to something like fiber, our body can't actually break that down. So we don't really release that as sugar. But part of the problem is, I mean, you said it earlier, if you've got a good diet, you won't get tooth decay. The problem is, there are many people who still get tooth decay, even though they don't have sweets and chocolates and blah, blah, blah. The reason why they're getting tooth decay is because they're eating either refined or even just starchy carbohydrates 3 to 4 times a day. The problem starts with the food guidelines. The food guidelines that we've had are, people think it's scientific, but actually it's been a historical thing that really emerged through politics, food supply, and actually corporate interest. And therefore and actually just the fact that, well, if we hadn't eaten the way we had, with masses of grain and going into all of our food, as a species, we probably would have actually, starved. So we needed it. But the question is eating refined carbohydrates or starchy carbohydrates frequently good for us? And in the food guidelines currently, you can go to NHS hospital, it will actually say on the wall, it will show you these kind of patterns of foods to eat. But underneath the carbohydrate section, it says, base all of your meals on starchy carbohydrates. Problem with that ends up with the calories that come from carbohydrates being between 45 and 65%. If all of your meals are based on starchy carbohydrate, you are automatically entering an area where, if you are relatively sedentary, and I do say that with a caveat, because if you're highly active doing high rocks and marathon runs every week, quite frankly, you can probably eat as many carbs as you want. But if you're sedentary like most of the population, you are going to end up with elevated blood sugar, elevated insulin, and then the cascade of metabolic issues that then follow. So the problem is, what we're basing our whole diet on, that we're saying is good and correct, is not necessarily correct. I'm not trying to say to people, you need to cut out all carbs. The key is that we should be restricting them out. Maybe we can get into that a little bit later in what I say to my patients. But fundamentally, I think we're starting with the wrong scenario, and people need to understand the concept of glycemic index and how that starch breaks down into your body and then what it's doing later. And I think another thing is that we think that caries, there's something people can look up called the SHIP study, SHIP, by the way, on the end. Very good study. My jaw dropped when I read the study, because I always just think that, HbA1c, which we'll touch on a little bit, but hemoglobin A1c, if that was high, well, that's a Perio problem, and maybe we'll touch on why. But believe it or not, if your HbA1c, meaning your blood sugar, effectively HbA1c means your glycated hemoglobin. For people that don't know, an HbA1c record is basically a 3-month average of how much glycated hemoglobin is stuck to your red blood cells. So it's quite a good reflection, but it's also a reflection of how much glycation is on every cell of your body, not just your red blood cells, but it's just measuring the red blood cells. So the point being is that SHIP study showed that people who have elevated A1C, even if they're controlled for diet and oral hygiene, meaning their diet is they're not eating sweet things, they're not eating sugary things, and they're brushing well, they have a significantly increased risk of caries. Why? Because actually the mechanism is that your gingival clavicular fluid has more sugar in it. Your saliva has more sugar in it. So, if we talk about what biomarkers dentists should be aware of, we all should be aware of the HbA1c. That should be basic dentistry. And the reality is, it's easy to find out. And the irony of it is, most people, particularly over 50, it's sat on their NHS app anyway. And we're not even trained to look at it. So, I'll answer quite a few questions probably with one point, but I think the fundamental point with that is that we have a real misconception of what sugar is. And the sugar that the obvious sugar that goes into our mouth, that's one thing. But the sugar that's actually going in as potatoes, pasta, rice, etc., is breaking down in our body and actually also providing a form of sugar as glucose in our bloodstream. And that can drive, whether it's driving insulin resistance, blood supply issues, perio, etc., it can also effectively drive caries too.
Well, with your patients then, if you're used to saying, it's the whole non-milk extrinsic sugars, and make sure you have your sugary things at meal times and reduce the frequency of sugar attacks, as we call them, I think that the way you now communicate to your patients about caries is different. You bring the whole body into it, and therefore you also talk about. But how has that been? Have you met resistance from your patients talking about general carbohydrate, starchy carbohydrate? Because it challenges a norm. It challenges what we see every time we go to the GP, a hospital, like the food pyramid, the ideal plate and stuff. So tell us about how you found communicating this with your patients.
I think the key here is not trying to do anything too extreme. So this is what I say, and I'll kind of role play it for you. I say to my patients, look, if you're looking to reduce your risk of tooth decay, this is what I would do. And I say, this is what I did. And I've gone even further, but this is what I would do. If you're putting food into your mouth 4 or 5 times a day, let's say you have 4 meals or even 3 meals or whatever. If 1 or 2 of those meals you could remove all starchy carbohydrates and refined carbohydrates from, so let's say for lunch, if you eat meat, that's a bit easier. You can eat fish and eggs and maybe a bit of green salad with it. Even though there's some carb in green salad, it's minimal, okay? But if you can have 2 meals that are kind of technically, or 1 or 2 that are kind of technically keto-ish, okay, then the other 2 meals, you can have carbs, but try and have those meals closer together. Meaning, look, it could be an afternoon snack and then maybe your evening dinner, or maybe an early lunch and an late lunch and early dinner. What that would mean is you would have about 16 hours around the clock where you've not had any carbohydrates. If you do that, I absolutely guarantee your insulin will reduce. And I do try and explain what insulin does to people. Your insulin will reduce, and actually your blood sugar is going to reduce. Your blood sugar will reduce, and your insulin will actually follow as a result. Now, the blood sugar and the starchy effect in your mouth and your teeth, etc., as that reduces, that will definitely over time lower your A1C. 100% is going to have an effect. How much? It depends on other factors as well. But I say to the patients, and I guarantee you, if you do that, you're going to lower your chance of tooth decay. You'll definitely lower your chance of tooth decay. There's still a chance, but you will lower it. And you know what? Saying that to people, not every patient listens. Some of them don't even listen to a word of it, and they'll carry on doing what they do. But it's interesting how many do. And I have to say, a lot of them do. And as a result, and yes, it's anecdotal and you're kind of seeing people come in, but the condition of patients' mouths is significantly superior on the people that are doing this to the ones that aren't. Particularly from particularly looking at perio health and gum, inflammation on the gums, and basically the amount of simple plaque that you get built up because you're not providing the substrate for it to be there to begin with. So I've really had no resistance. Occasionally,
have you noticed these patients come back and they're looking a bit like slimmer or something as well?
Some people, normally, the conversation the last few years has actually started generally with a patient walks through the door and they look at me and they say, "God, what have you done? What have you lost weight?" and et cetera, et cetera. I just talk to them a little bit about it, and yeah, you do see it. And obviously, I'm not sitting there measuring it. We're not weighing them or anything like that, but interestingly, we are testing their A1Cs, and we're starting to see that come down in the people who are. It's still early stages, but that's a good sign, and it's an important sign because the hemoglobin A1C is actually very predictive of lots of problems generally. And even on its own, hemoglobin A1C, people should understand it's actually not perfect because your hemoglobin A1C only starts to rise if you've had elevated insulin for about 5 or 10 years. So the pathological damage that elevated blood sugar is one thing, okay? That causes glycation, which can strip your glycocalyx and all your blood vessels. It can damage particles. It can cause advanced glycation end products. It can cause inflammation. Okay, so that's one cascade of pathological pathway, high blood sugar, okay? Insulin has its own pathway of pathological issue. So high insulin. So here's the thing. If you're eating, every meal you're having carbohydrates, your insulin will be higher than somebody who isn't having carbohydrates. Simple as that, okay? Particularly if you become what they call insulin resistant, which we might touch on. If your insulin climbs, there's several things that happen. Number one is high insulin will cause reduction of nitric oxide production in your blood cells and your endothelial line, etc. And obviously, you need nitric oxide to allow any vessel, whether it's a capillary, an artery, etc., just to open. That allows vasodilation. So if you reduce your nitric oxide, you're getting more vasoconstriction. In fact, this term that we have of idiopathic high blood pressure, elevated high blood pressure, where they don't know what's causing it. The only reason they don't know what's causing it is because they're not measuring the insulin. If they measured the insulin, they'd find in 99% of those patients, they've got high insulin because doctors don't measure insulin. The NHS doesn't really measure it. Why? Because actually treating glucose is easier to do with a drug. So it's easier to drug glucose down. You can't drug insulin down. The only way you get insulin down is by changing the diet. Okay. So the second thing that insulin does is also really important is because it's like a growth hormone. Every single blood vessel, capillary, artery, imagine every capillary trying to reach your gums, it actually grows internally and the wall thickens and stiffens, which reduces the blood supply. It stops the perfusion of oxygenated blood through that tissue, wherever it's going to be, your eye, your brain, etc. And therefore you're going to get pathology at the other end of that. So high insulin is in reality the elephant in the room. That's probably one of the primary pathological driving factors of just a myriad of disease, including perio. And there are good studies that show there's a great one by Korean study by Song et al. I may maybe be able to provide you some links at the end of this if you want, Jazz.
Yes.
Al, where effectively they look at non-obese individuals, and they're non-obese. And so, yeah, I mean, if you're obese and you've got type 2 diabetes, you're going to have high insulin, you're going to have perio. Okay, fine. But what they showed very clearly is that even if you're non-obese, but you have severe insulin resistance, meaning your body's producing so much insulin over so many years to try and keep your glucose down, and your glucose is kept down. Okay, so your HbA1c is low, but you're still insulin resistant. Those people, that risk factor is an independent risk factor for severe perio. It's almost, that study shows that it's almost impossible to have severe perio in a and without being severely insulin resistant, if you see it. And then it's logical, isn't it? Because, okay, we know perio has multifactorial reasons. Bacteria is a big part of it, of course, but then what's allowing that bacteria to proliferate? You've got the actual substrate that's there, that's been coming from the food. You've also got the conditions where blood supply is now not perfusing correctly, and oxygen and the right kind of macrophages, et cetera, are not getting through to actually combat.
It's a modulated immune response, a reduced immune response.
Exactly. So insulin is one of the big keys, and as I say, it's. And so when I'm talking to patients, I obviously don't go into that level of detail. I think the key thing is I am just trying to make them understand and trying to do it in a way where you can change diet a little bit that's not too scary. And do you know what? I really wish the dental profession as a whole would do that. I really wish the CDO and all those people would actually look and just seek to tweak the food guidelines. No one's telling everyone to go keto. I know you've just done it, I've done it, and there are huge benefits in keto temporarily, but a little bit every now and then could potentially have huge dental benefits as well. Sorry, I'm rambling on a bit there, Jazz.
No, but I appreciate that very much. But when you communicate with your patients, which you gave us an example, the role playing, you talk about the caries, talk about perio, but then do you say that, look, by doing this change, the HbA1c will come down, and in turn, it's going to be good for your heart, your organs, and your blood. Do you mention the sort of holistic and body-wide benefit that someone may experience?
I do, and I talk about. I mentioned the term metabolic syndrome. For patients who are interested, I talk a little bit about fasting and what that does. I mean, patients who have kind of, got the mental capacity. That's maybe the wrong term, but they've got the interest in it. I talk a little bit about fasting and why I do it. But everything is never in extremes. Okay. I mean, I know there's people that, they might be carnivore or this or that. I would never talk about anything like that. Really what it's about is about explaining to the patient what causes disease and helping them understand that this kind of glucose insulin dysmetabolism is actually the primary driver for most of these problems. Sometimes I show them a study. There's a really good study called the Women's Health study. It's a 21.4 year, maybe 24 years now, where they look at coronary artery disease, heart disease, and then they look at the conditions that have been most closely associated with it, okay? And then the biomarkers that are most closely associated with it. Now, I would imagine, and maybe you would, as Asians, we kind of thought all these years that familial history is at the top of the list of risk factors, near the bottom. It's there. It is a risk factor, but it's near the bottom. What's top is type 2 diabetes. What's below that is what they call metabolic syndrome, which is actually type 2 diabetes, but not quite there yet. High blood pressure, just below that as well. Now, what causes high blood pressure? Metabolic syndrome. It's all the same thing. And then if you look at the risk factors for biomarkers for predictive for heart disease, coronary artery disease, cholesterol's there, and LDL cholesterol's there, but it's down low, sort of 1.5 on the risk factor range. I think nearly 4 or 5 times more indicative is lipoprotein insulin resistance. So if you've got insulin resistance, you are far more likely, that is the driver for heart disease. It doesn't mean the cholesterol's not important, it is. And I would never tell a patient, stop taking your statins and blah, blah, blah. You never say that. But all you're telling them is what's actually causing heart disease. And what's causing heart disease is actually fundamentally elevated blood sugar. And what's going to cause elevated blood sugar? Fundamentally, it's going to be carbohydrates. You can add a load of other stuff to it to make it worse. Smoking, poor quality fats, etc. But it's this frequency that's actually fundamentally causing it. So I go, I'm certainly not going to try and conflict anything with their doctor at all. Occasionally I get a patient.
I mean, medico-legally, we have to be careful there, don't we? Right? But you can't. And I really appreciate that. Yeah, you don't go into extremes, even though you may observe on your own body, out of choice, what some people may perceive as extreme. Right? People will perceive that you don't you don't eat carbs anymore. Right? I mean, they might say that's a quite extreme. But what you teach from your perspective. And what I appreciate in terms of the role of an educator, right? The role of an educator is not to dispense everything in your brain into someone else. It's to inspire them to then follow their own journey. And so what I imagine what happens is that those patients that resonate, that understood that they go to Gemini or ChatGPT is like, what about this and what about that? And then they start making changes and that's a much better pathway because now you've sparked this interest. You spark them into the rabbit hole of their health, which in turn will improve their periodontal outcomes, to reduce their caries risk. But you know what? It's going to do a whole lot of other things for their body. So I think that's that kind of careful, tactful approach to inspire them rather than to share or the more extreme things that could be perceived that we do.
Definitely. I totally agree. And that's also why I think it's important as a profession.
Hello, YouTube Protrusive. I know you're watching on YouTube and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
We need a bit of a discussion to actually decide what is most important, because of course in this day and age, there's like a billion biomarkers. There's salivary testing, there's this testing and that testing. On what does it all actually mean? The reality is, I mean, there are papers that do cover a lot of this stuff, and there's a good papers on salivary biomarker testing, and it comes to the conclusion that it can be useful, but it can also create a lot of false positives, and it needs a lot more investigation. And there's certain things in salivary testing that I think are going to go faster than the others, such as you've probably heard of MMP8, the proteinase. It's like a way of detecting early perio. Before it kind of even happens. And that's, I think, a really positive thing. And then some of the IL-6s and IL, which actually can also reflect that this is going on. But I think if the deeper you go into salivary testing and like, oh, you've got this bacteria and that bacteria, and you might have this strain and that strain. And I'm thinking, really, how important is that compared to an HbA1c of 6.5, which you didn't diagnose? Do you get my point? I think for me,
is it Pareto principle, right? 80% of the damage comes from the 20%, right? The HbA1c is a low hanging fruit that if you fix that, then actually your biomarkers improve massively.
Exactly. And then the other big one, I think, is VIT-D. I think VIT-D is.
Yeah. I was just going to mention VIT-D because from mine, like I've been following Pavkyra and Hatta Malgraphi, and in the implant world, they're getting good at, and before I place this implant on this person, then yes, they've cut out their smoking or stopped their smoking, but can I just check their vitamin D levels? Because actually, and they've been, from what I'm reading, so many patients were actually low in vitamin D. And so now some people are not even testing, like, hey, are you taking a vitamin D supplement? Are you not? Okay, make sure you get on that, and let's wait a while, and then we'll test, and then we'll do the implant. So vitamin D is a huge one. Anything you want to add to that before we...
Well, I would say vitamin D is really, really important. I mean, I'm actually astounded why it's not talked about more in dentistry. But you know what? The more you read about the history of vitamin D, you actually realize there's a reason why it's not talked about in dentistry. And I would encourage everybody, and I will send you the link to this article, to read the history of the introduction of what happened with vitamin D. I'm going to call it that, with the American Dental Association in 1955. Because pre-1955, their primary treatment strategy, and they did 15 years of research on this, pre-1955, their primary treatment strategy to stop tooth decay was low carbohydrate diets and high vitamin D supplements. Now that works. It works. Everyone knows it works because you've removed the substrate and you're optimizing immunity. That got binned within about 2 or 3 years. Now, if you think it got binned because fluoride outperformed it scientifically, you're dreaming. This was all a commercial decision, because they started taking money from commercial companies. Now, that doesn't mean fluoride is bad. Of course, we know fluoride works. It's one of the best things ever in dentistry for the diet that most people eat. But to disclude vitamin D and junk all the science on it is absolutely scandalous. And the fact that actually you can go through dental school and not really be aware, okay, maybe you know a little bit about vitamin D and what it's important in... We know it's important in tooth development, but why would we not be testing it? I mean, there's good studies that show that even if you're an adult and you have low vitamin D, this is beyond the tooth development. It strongly correlates to increased risk of caries, and there's some biomechanical reasons for how that can happen. It's to do with the immunity and blah 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 blah. So why have we forgotten about it? There's, we know. I mean, there's a great study. I would encourage everyone to read the comprehensive review of vitamin D in dentistry. I think it's Joel Botello. That study looks at various areas. So looks at caries, shows it's strongly relevant. Looks at perio, strongly relevant, particularly with the immune pathways. Looks at oral lesions and cancers, strongly relevant. Looks at ortho, and it's relevant. Now, the only problem with the ortho studies are they're not human. All the others are human studies, okay, on all the other factors and implants, etc. Ortho studies have only been carried out on animals, but the studies that they've done, of which there've been quite a few, they've shown that if an animal has low vitamin D, and they do ortho on the animal, which sounds awful, okay, but they do ortho on the animal, those teeth move significantly more slowly.
Wow.
And the reality is bone metabolism in animals is not wildly different to bone metabolism in humans. Okay. You still need the calcium. You still got those, basically the osteoblasts and osteoclasts exactly the same. So why would it be any different? So here's the thing. If we know all of this stuff, that we can have a significantly increased risk of caries, significantly increased risk of perio, significantly perhaps issues with ortho, and also implant failure. I mean, there's a systematic review on implants, and they look at all the kind of human studies. And one of the studies, actually a really good study, looked at what the patients had that sort of contributed to why the implants failed. They looked at failure rates and then what the patients had. Now, we're always jumping up and down about smoking and perio, of course, and I think there was like 6.8% and 3 or 4%, 6.8% for smoking. Severe vitamin D deficiency, 11%.
Wow.
outranked all of them. Now, obviously, when they're combined, it's all even worse.
Mm-hmm.
And so you've got all these people telling patients, you mustn't smoke, you mustn't smoke, you mustn't smoke. But patients spending 50 grand on a full mouth rehab, and no one's checked their VT. And I know implantologists are getting on this. I see, like you say, Pab and all these guys. It's brilliant to see they're getting on this. But there are still a lot of people out there that aren't. And why would you take that?
Well, not just for implants, but like if you're going to do some grafting or you're going to do some significant periodontal therapy and the patient's spending thousands, right? Then how to optimize, it's not even biohacking, it's bio-optimization, right? It's not a hack, it's just making sure that your immune system is responding in the best foot forward.
Definitely. And here's the other point to all of this is, if you look at the UK Biobank study, I think it's 2024, they looked at people in the UK and then they looked at different racial profiles and how many people are vitamin D deficient. When you understand the consequences of study, it really does make you question the National Health Service and some of the thinking behind it. And I mean that with the most respect. My whole family are doctors here, okay? Because what they found is that firstly, 57% of South Asians, you and me, are not just deficient, they're severely deficient. 50% in some, 57%. Afro-Caribbeans, 38%, Chinese, 30%. White Europeans, 17% are severely deficient, but 65% are still deficient. So if we know that most of the population is deficient, why are we not doing anything about it? This is what I find completely bizarre. And the answer to that, I don't mean to say this in a political way, but the answer is partly due to the way that medicine as a profession works. And I know that because, as I said, family are doctors, my best friend's a GP. The problem with a lot of medicine, particularly GP medicine, it is fundamentally algorithmically driven, that everything is about, here's a condition and here's a problem, there's a drug you're going to get. It is not based on, goes back to what we talked about at the beginning, Jazz, it is not based on solving the root cause problem. So while we see vitamin D testing going up, a little bit you see more GPs doing it, the fact that it is not there's no routine screening for it just tells you everything you need to know. And I think certainly as dentists, when we know what the dental implications of it are, the reality is there's going to come a point, it's probably here now, where it can be used for your own medical legal defense, and B, it could be used to turn you over at the same time. I think one really interesting thing I'm finding with this, and particularly tracking this data, is I actually think there's going to be a ground-shaking change in medical legal outcomes. And what I mean by that is, let's say, for example, you've got a patient who's had perio, maybe he's got some implants. Let's say that you've tracked their VIT-D and HbA1c. It's been low. Patient doesn't want to do anything about it. HbA1c is poor. You talk to the patient, they don't want anything. Already at that point, you need to consent the patient, telling them, I found this out, and please be aware, if I do your implants or do your perio, the success rate is potentially worse. So there's already some defense for you. Now, if you then go on and see that patient, do the treatment, and then who knows, over the next 3, 4, 5 years, there's bone loss, there's perio in other areas, and you're tracking HbA1c high, whose fault's that? Whose fault is that? Now, of course, we have to diagnose it, and we've got to do everything to treat it, but I think by not tracking HbA1c, VIT-D, and some of these other biomarkers, we're actually, as a profession, leaving ourselves open to more blame for outcomes than perhaps we should be. And I'm not saying it's going to, totally remove all medical legal claims, but I think that, there is potential. If I was an indemnifier, I'd be thinking, do you know what? This could be less payouts. Because if we can show someone's VIT-D has been low during the treatment, which you can argue maybe the treatment should be done, after the treatment, and then long-term after the treatment, and that implant fails, well, there's actually a scientific reason for a contributory factor to why.
It's another objective data point that supports the poor wound healing mechanism and immunity of that patient. And it's nothing that the occlusion was wrong in the implants, nothing that the implant wasn't placed in the best way. There's more to it than that.
Definitely. I mean, and there's actually, from an implant placement perspective, there's some good evidence that shows basically if you've got your macrophages that surround within the bone surrounding an implant when you place them, and all the soft tissues, etc. There's two phases. It's called an M1 phase and an M2 phase. The M1 phase is where the macrophage is sitting happily, doing what it needs to do, not attacking anything. Low vitamin D causes it to revert within 2 or 3 days to the M2 phase, where it literally turns into a bloody dog, sort of biting everything around it. And so that's been shown, it's been proven. If you're doing anything, so like you say, grafting, surgical treatment, anything, it gets to the point, the more you understand this, the more crazy it would be to carry out that treatment without at least knowing. And if it's low, and the patient still wants to do it, that's their decision. You can't say, I mean, maybe you could say, no, we shouldn't do it, blah, blah, blah. But it's ultimately their decision, and they then have to take some of the responsibility of it. And hopefully we get the FIT-D up. But then the conversation comes into, are we diagnosing and treating that deficiency or not? And it gets a little bit hazy, but I would put that down to what level they are. So if you were to ask me, Tiff, should you treat a patient with low VIT-D with vitamin D? Well, what I would say is it depends on severity. Fundamentally, if their vitamin D levels are sub 20 nanograms per mole, that's severe. And I would definitely send them to the doctor. The level should be 30 nanograms per mole. That's what they call sufficient. But actually, it's not great. If they were just under, like 27, 28, 29, I'd probably say to them, look, take some vitamin D, make sure you take it D3 with K2, and take it for a few weeks. I can refer you to your doctor if you want to, but actually, if you take it for a few weeks, let's call it 12 weeks, I'll test you again and we'll see where you are. I think that's perfectly okay. There's nothing wrong with doing that.
Because we are in health, I mean, we talk about the medical legal perspective, but we are healthcare practitioners. This is not something that, I mean, there is a gray area in the TMD world. Like, we can't diagnose a headache. Headaches very much, the GP and neurologist, that kind of stuff. But there is a subset. There's a TMD headache, which we could do our test and it comes out positive. Okay, well, we suspect there's a TMD headache, but you should also get cleared and checked out. And so we're not really stamping on the feet of our medical colleagues. But when it comes to quite a basic principle in health, then, and especially if it's like, we're not recommending something that's controversial, it's vitamin D for Pete's sake, right? It's vitamin D. So it's a positive health message. What I love about all this, Tiff, is the same thing that I love about being able to talk about sleep for the last few years of my patients. I moved away from single tooth dentistry a while ago, but it's just brings so much more satisfaction and breadth to our career and job when we go in. And yes, we're talking about the teeth, but we're talking about their health and sleep and how energized you are throughout the day. And then when you bring all this stuff into it, then the overall health. And this is the way that we're going, right? We're going to become more health conscious as a whole. Now, there's a lot more things I want to talk to you about. Holistic dentistry, biological dentistry, where that comes in. But I think the question that needs being answered first is, what are you currently testing your patients for? Is this a routine thing? Like, when a new patient comes in, they all get photos, they all get blood tested. Is it that? Or is it like an optional thing? And how does that work? And what do you advise for general dentists who are listening today?
So what we're doing mainly at the moment is HbA1c and vitamin D. We also do test for iron, ferritin. I'll probably do that more based on oral signs and symptoms. And then we can also test for CRP, which is C-reactive protein, which is an inflammatory thing. It's useful, but it can also, you can get that can be high if you have, a urinary tract infection. You know what I mean? It's sometimes a little bit, So I think HbA1c and VIT-D are good places and basic things that dentists can do. Now, a new patient walks through the door. I don't immediately get the blood test kit out and say, right, we're doing this, okay? The first thing we do is we put it in the medical history form. And on the medical history form at the bottom, it says, do you know your HbA1c levels? Do you know your vitamin D levels? And then I say to the patient, I look at the form and virtually everyone says no, okay? And then I say to the patient, we are now asking these two questions because this is an ongoing thing we are tracking in dentistry, because both of these two biomarkers, so to speak, they have a real significant impact on your dental health long term. There's lots of evidence to support that. So the first thing I'll say to the patient is the HbA1c, I'll explain what it is. And then I said, the first thing you do, you can actually just check on your NHS app because it might be on your app. And if someone's over 40 or 50, it's a basic standard blood test. It's there. They would have it. It might be a bit old and it might be a bit out of date, but it's a good start point. And we then may, if it was a little high or something, I might say to the patient, it would be quite useful to test that again for you. VIT-D, rarely on it. It's rarely on the on the doctors, but occasionally it is. Now, if somebody, from a kind of treatment pathway point of view, now if someone's having ortho, I'm starting to do VIT-D for free. Because it's not expensive. I mean, a VIT-D test costs the practice like 12 quid, something like that. Okay, it's not a lot.
And I want to know, is it instant? Is it a finger prick, or do you need to be trained in venipuncture?
Well, no, it's finger prick, but there's still a bit of a technique to it. So you do need a little bit of training, but it's a finger prick test. I mean, there's things like, when you're doing a finger prick test, you don't take the first drop of blood, you take it from the side. There's bits and pieces, basically. And then, yeah, I mean, it basically then goes into an immunofluorescence assay reading machine. Now, I've actually been testing about 4 of these over the last couple of years, and I found a couple of them are actually really accurate. Now, how do I know they're accurate? Because what we've been doing is we've been comparing the tests to very recent blood tests and actually some lab results as well. So, and we've managed to do that across quite a range of different patients. And I found that actually the accuracy is pretty good. There are other things to bear in mind, like the temperature makes a massive difference. So if you did a finger prick blood test in this 30 degrees centigrade, the result might vary by 15-20%. It's just useless, basically. So everything needs to be kind of correct. But we do them. VIT-D takes 15 minutes. HbA1c takes 5 or 6. Nothing.
This is how many minutes it takes for the machine to give you the reading.
Yeah. So yes. So you're going to do the finger prick. You're going to mix it. I mean, it's literally once you've done the finger prick, and then you basically mix the blood with the diluent. You dropped it into the dropper. You put a cassette in. That takes probably 2 to 3 minutes to do. Then it's about another 15 for VIT-D, but it's actually just 6 minutes for HbA1c.
And it's the same machine, or have you have to get like multiple kit?
It's the same machine. Yeah, the machine we use is basically it actually will do about 25 different tests. Many of them are totally irrelevant to dentistry. I mean, you've got like kind of a variety of hormones and all sorts of stuff. So obviously, I think more primary care medical people or pharmacists and stuff, maybe they might use a similar sort of thing. So it's really easy. It's not there's nothing complicated about it. It produces a score, you've got a QR code, goes to the patient's phone, all very nice and simple. So yeah, I mean, that's what we do. As I said, I'm doing it now for ortho patients for free. Interestingly, a couple of ortho patients who, where cases have dragged on a little bit, I've actually, where their line has just not quite got where we've got to. And surprisingly, I've sort of said to the patient, I'm going to do a VIT test for you. VIT test for you. They were really low. And I think, so it's like, it might not be the only reason, but it kind of helps to understand a little bit. Okay. And it's good that the person found out the VIT was low anyway. So implant patients, in my practice, we've kind of set the situation up now where all implant patients would have a VIT test done included for free, because again, it's peanuts basically.
Yeah.
Ongoing Perio patients, I've been educating and I'm trying to educate my hygienist to do it. I mean, they just charge a fee and they say to the patient, look, this is why we want to do it. It's a good thing to know. Ideally, they do it every 3 months, which I appreciate that might be a patient's going to want to do. But the HbA1c test is even cheaper. It's like £8 or £7, nothing. So basically, we charge £35, £36 for it. It's just peanuts, really. But it's good information for the patient to know. So yeah, that's where we've started. We're looking into MPA. But at the moment, I think for me and in our practice, just gathering data and seeing these sort of trends of who has high A1C, which patients have it. I mean, it's not surprising who has it. The ones that have low VIT-D, et cetera, et cetera. Okay, so again, to be honest, I can almost look at someone and know now. But the reality is that if we know that and we're now tracking that data, we are giving the patient information, we're educating them. We're also providing an element of record taking and perhaps for defense as well. It's a no-brainer, and it's just got to happen. I can't, as I said, from a VIT-D perspective, I don't understand why the silence from dentistry. Why the silence when we know all the dental benefits of it? Incidentally, vitamin K2 as well. Vitamin K2 has profoundly huge dental benefits as well. Moving calcium out of the bloodstream into teeth and bones. Why is that not basic dentistry? You see, this is the point. Partly, I think, because our medical education that we get at dental school is coming from the medicine profession, not the functional medicine profession. If you see my point, not the preventative medical profession. We're getting our information. That's why diabetes is talked about the way it is. Diabetes is one of the most garbage terms I've ever heard of. Okay, that's a really controversial statement because people act like diabetes is an on-off switch. You've got to a point now you're diabetic. No, it's not. You've been diabetic. Diabetes and pre-diabetes are exactly the same disease. They're the same disease.
It's just further moved along, isn't it?
All it is your blood sugar's reached a certain level where your insulin's given up, but you've still got atherosclerosis. You've had it for 10 years, I'm afraid. It's not a nice thing to know.
It's like it's no longer diabetes. It's you are diabeting. You are
well, you're diabeted. Yes. But here's the point. Look, I love the BSP. I think what they do does is amazing. But if you read a lot of the kind of terminology about treating diabetics, a lot of the terminology is, if the patient is diabetic, you do this, this, and this. But that actually reflects, and try and say this with the utmost respect, which actually reflects a medical profession-wide misunderstanding of diabetes, in that they are using a measurement of when you prescribe metformin versus where there is actually metabolic disease starting, and what is that spectrum.
Because the harmful things that are happening in your body are already happening. You don't have to wait for that, cross that threshold. It's a continual process.
Exactly. And the bottom line is, I mean, and you were talking about what I say to my patients, and sometimes I say some blunt things, and their patients aren't upset, but I say to them, and sometimes
Your patient has been seeing you for 20 years, so
I say to patients now, look, they say, what should I eat? And I say, well, look, if you can get a hole in your tooth, you're eating the wrong food. Simple as that. If you're telling me you're not eating a lot of sweets and chocolates and sugar, okay, there's a reason for it. But if you're not doing all of that stuff every day and whatever, and you're still getting tooth decay and gum disease, you're eating the wrong food, because your mouth is your body. I don't like this mouth-body connection BS term. It should never be called that. The mouth is the body. It's the same thing. It is the gateway. Yes, it is into the body, but it is the body, and everything that affects our body, our heart, our internal organs metabolically is going to affect our mouth metabolically in exactly the same way. And this idea that it's a kind of focal infection that occurs there and it's a focal disease that has no implication anywhere else was trash. And I don't understand where that actually ever came from. We are effectively mouth doctors, and this is what we should be doing. But still, as you say, what we're doing ultimately is screening, not diagnosing, not prescribing. We're screening, and we're just providing and adding this data to our armory, so to speak.
And once again, an opportunity to step out of tooth-borne dentistry and look at the patient as a whole, and what a pleasure it is to be able to do that. Now, Tiff, all these things you do, does this make you a biological dentist?
I'm laughing.
Biological Tiff.
Patients ask me, "Oh, are you a biological dentist?" And I actually say no. I said, I am interested in your biology, but I do believe that some of the things the biological dentist movement are doing are good. I think there's a lot of good stuff there. My concern, and I appreciate this is a controversial thing to say, but my concern is that sometimes it seems to be conflating issues to effectively upsell dentistry. So the classic one, which I think most rational dentists with a scientific background would all agree on, is this bizarre thing that's sweeping online on the internet, where a root canal, even apparently a healthy one, okay, well, what they just say is all root canals are going to cause a focal infection, which potentially could lead to cancer. There's a study that says somebody had root canals on this side and then they got this cancer on that side of the body. I mean, we all know how poor the basis of that science is. The argument for those people is, no, it wasn't the root canal. It was the food that caused the cancer, the same food that causes the root canal. Food and the environmental factors are probably what caused the cancer. Okay, elevated sugar. Read the Warburg effect if you want to understand how cancer works and what feeds cancer. So ultimately, it's got not that the root canal's there. Yes, we know that bacteria can cause bidirectional issues where everyone's getting excited rightly about P. gingivalis, and that, it's in your mouth. And when you open up an artery in a heart attack, 78% of all the bacteria are P. gingivalis, outranking everything. But that's still not proof that caused it.
No.
Still not proof. Okay, it's a factor. But again, a lot of this is chicken and egg. If you were metabolically healthy and your whole blood supply to your mouth and gums were totally healthy, would it have provided an environment for P. gingivalis to survive, to then enter your bloodstream? And then also that poor metabolism has probably been, with all that vasoconstriction and damage to the glycocalyx in your blood vessels, all of that's been going on for years, creates an inflamed arterial wall that allows a bit of a lipopolysaccharide wall from a P. gingivalis to get stuck. LDL cholesterol gathers around it and then causes, starts to create a blockage, blah, 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 blah. You get my point? So I think the problem with the biological movement is, it seems like I see all these videos of these dentists saying, you shouldn't be having root canals, you should be having white implants. Well, I write quite regularly underneath that. I say, do you know what would be much cheaper for the patient is that if we just taught them a slightly better approach to diet and nutrition, and that if they just reduced frequency of carbs, understood what insulin resistance was, they would probably massively improve their health, and they don't need to spend $8,000 for a ceramic implant instead. I'm actually aghast that this is happening.
It's disinformation. I mean, there's such thing as misinformation, but this is disinformation.
It's disinformation, and it's just cynical money making. And there are, there may be some good intention, and I know that there are people who are doing biological dentistry who are well intended, and I can see a real spectrum. I don't think calling someone a biologist is they're all doing the same thing. They're not. Some, I think, are doing a really good job and looking at kind of holistics of healthcare, which is fine. I get that. But I think the minute you start to sort of, you have to upgrade all your dentistry is causing your problem, I think it's just irresponsible. And you know what? Maybe you do, fine. But if you say that to somebody who is actually metabolically unhealthy, who's clearly got non-alcoholic fatty liver disease, whose tongue is twice the size it should be because there's 45% of the tongue is highly inflammatory fat, which is also another factor, and you're saying, talking to them about all their dentistry being the primary problem, you're actually the problem. They should spend 1, 2, or 3 years, understanding what good nutrition actually is before you even think about attempting that dentistry, it might be justifiable. And don't get me wrong, it might be if the root canals are leaking, blah, blah, blah. And then the second thing is, people talk about root canals being poor. Well, it's probably because a lot are poor, because a lot of the people doing root canals shouldn't be doing them. And, you get my point. I mean, root canals done by a well-trained dentist, and a well-trained dentist can do them well, or a specialist, are of significantly higher quality than someone who isn't doing. I mean, tell you what, they'll be significantly higher quality than mine. Mine would be a pile of absolute cack. I don't do them. But if I had to do them, God knows what I would cause. You get my point? So I think that I really, I don't want the biodentistry thing to be thought of as a joke. And I know there are people who make fun of, dentists talking about vitamin D. I've seen people making joke about it. I say, if you joke about vitamin D, you're dumb, quite frankly. I'm sorry to say that. You are pretty stupid, actually. But equally, I can see why people would attack this idea that, biodentistry is all about changing your, getting rid of your titanium implants and sticking, you need good evidence, really good evidence to support that. And, other than anecdotal evidence, there's very, very little out there right now that would give any reason for a patient to want to do that.
Well, there we have it, guys. Tiff is not a biological dentist after all, but he respects the biology, and it's been refreshing to hear about how you've incorporated it, and furthering this sort of, you said, it's not really a connection between the mouth. The mouth is part of the body, and remembering that, okay, we are in healthcare, and we have a right to be able to discuss these things, especially if it's going to benefit them in the metabolic issues and the dental issues that they're having. So, Tiff, my question to you is, what's the next step, right? If a dentist listening, they're interested in this, is this something that you teach on? Is something that we can attend of yours? How can we learn more from you?
Yeah, I mean, I've done a couple of webinars. I did the one like last year or a year and a half ago, and I did another one the other day on blood testing, the whole blood testing approach and practice, and then we're gonna reformat that and put that out on the IS page. But I'm actually I'm going to be basically doing like a 1-day metabolic health program where half the day is all blood testing and half the day is going to be on the basics of diet and nutrition, what I do with my patients and what we do step by step. Because interesting, I thought blood testing would be really easy to show people how to do, but we had like an IS trainer meeting and I did a load of blood testing on the trainers, and I said to them, right, now, you have a go. And everyone was, I'm not sure what to do, not sure what to do. And it's interesting because because I do so many, it's just like, bang, bang, bang. But it is something you need to be taught, and it's a good hands-on skill to do. I mean, obviously you can teach your staff and stuff to do it as well. It's easy to do. So yeah, we're doing that, and it's just I think it's sometime in October, and it will be on our website at some point. But it's something that I want to do.
Well, when you have that, please send me the link. I'd love to put it on, because people deserve to learn more. And what you've done is, you're so knowledgeable and you've shared with us, but those people who resonated with it and think that they can implement it to their practice to benefit their patients, you've given them something to think about, that rabbit hole to go down, and sometimes to facilitate that being even faster, that learning is really important to have educational resources like that. So I'll put that in the show notes.
Thank you. Yeah. I mean, what I'm trying to do is something that sieves out all the garbage and just, let's do something that's simple and easy and not overcomplicated, and that just makes scientific sense. And I think there's definitely a space for it, basically. So yeah.
Amazing. Well, Tiff, thanks so much for spending some time with me. It's so great to have you again after 6-7 years on the podcast. And I, when I said earlier about thank you from our profession for everything you're doing. So much you did in the ortho paradigm and how you changed that, and now with the health, and with all the right reasons. So thank you so much, and I really enjoyed our chat today.
Thanks, Jazz, and I'll say the same to you. You're absolutely killing everything at the moment. So I think everything you're doing in your teaching, your podcast, and everything. I'm sitting here admiring and thinking this guy really is on it totally. I'm really enjoying all your content. I think it's superb.
Appreciate that very much, Tiff. Thank you. It means a lot coming from you. Well, there we have it, guys. That's why Tiff Qureshi wants your blood. Thanking him again for a wonderful episode. Always so inspiring. I love his vision. I love everything that he stands for. For those of you watching on the Protrusive Guidance app, scroll down, answer the quiz, get 80%, and our CPD Queen Marie will send you your certificate. Our members get instant certificates, and every quarter we send you a summary of all your CPD and CE activity. We are, by the way, a PACE-approved education provider. And then annually we send you a massive summary, and you've got your own Google Drive folder where all your certificates lie, and our members find that incredibly useful. If you're not already a member, head over to protrusive.app and try us for a 7-day free trial. We have the ultimate plan, which got pretty much everything, but if you want access to Ask Jazz and all our AI from every single episode and every single masterclass combined, then you need the Infinity plan for that. I want to thank you guys for always tuning into episodes, whether they're super clinical or a bit niche like this one, but this is so important, as you saw or listened to have this overall health perspective in dentistry. And you know what? This is the future of dentistry. Until then, I'll catch you same time, same place next week. Bye for now.